This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. So now we're going to get into the meat of the ventilator talk, how do ventilators run. Everyone that's listening to this talk will have a different level of familiarity, but it's important for me to get us all on the same page with the same nomenclature. So in this graph, I'll be showing different types of ventilator breaths. On the x-axis will be the pressure changes, and on the y-axis is time is going by. So let me start with a spontaneous breath. We'll call that S for spontaneous. What happens is, if you're on the ventilator but are allowed to breathe spontaneously, you'll be at a pressure typically above zero. That's called PEEP or CPAP. Let's say this patient's on CPAP of 5. When they take a spontaneous breath, their breath pulls negative because spontaneous breaths are created by negative pressure in the thorax pulling the breath in. So you'll see a downward deflection of the curve. This is how we recognize that that's a spontaneous breath. Now, the next breath is an assisted breath. What happens with an assisted breath is the patient starts breathing spontaneously, but there is a trigger that recognizes the breath, and then the machine assists the patient by pushing the pressure in with positive pressure ventilation. Now, there are times when the patient's not triggering or we want to back the patient up. We're nervous that maybe they won't make an effort and they'll be apneic. So we actually can give an assisted breath off of a timer. The ventilator says it's time to breathe, Mr. Smith, maybe 10 times a minute. It guarantees they're going to breathe. When a positive pressure breath is triggered by a timer, that's called a controlled breath. I'm labeling that C for controlled. So these breaths are volume cycled. What I mean by volume cycled is in an assisted and a controlled breath here, we're picking a volume that needs to be delivered, and what we're not picking is how much pressure. One patient could require a low pressure, and another patient that has really bad lung disease might require a higher pressure up here. Now, there are other types of breaths that are pressure cycled. So in this breath, the patient makes an effort and the machine recognizes the effort, but rather than pushing a volume in, it simply targets a pressure above baseline pressure for as long as the patient's making an effort. And if it's really only targeting that pressure during the patient's effort, it's called a supported breath. So a pressure support breath recognizes the patient's effort, then it targets a pressure above baseline, let's say 10 centimeters of water above baseline, and maintains that pressure for the durations of the patient's effort. It's not timed. When the patient's not making an effort, it will stop supporting the patient. Now, there's an analogous breath that's also a pressure cycled breath called pressure control. In this case, we still target a pressure above baseline, but rather than the patient's effort stopping and ending the breath, we use a timer. We might say this is going to occur 15 times a minute, which is once every 4 seconds, and it's going to stay at high for exactly 1 second. So the patient just on a timer gets the breath, it stays at the target, and then the time is up and it drops down. That's called a pressure controlled breath. And then there's a third type of pressure breath, which I actually call an upside down breath. It's called pressure release. It's the same idea as pressure control. We're really controlling, but it goes in reverse. We keep the pressure at the patient at the high pressure most of the time, and then every interval will drop down to a low pressure for a short time. So the timing might be 15 times a minute or every 4 seconds we get a release breath, but the release might only be for 0.5 seconds, a very short amount of time. These are called pressure release breaths, and we'll get more into when we use these pressure release breaths, but it's usually for patients that have very severe oxygen problems, especially with ARDS or even COVID-19. So these last 3 breaths are called pressure cycled breaths because whether we're supporting a breath, controlling a breath, or releasing a breath from a high pressure to a low pressure, we're deciding how much pressure change there is. What we're not able to decide is what the volume is. We have to go back to the ventilator and look at the ventilator to see how much tidal volume came back. So in the first 3 breaths, the patient's effort triggers the flow. So in a spontaneous breath, they make an effort with this yellow arrow, and then the flow is allowed in spontaneously. In an assisted breath, the patient makes an effort. There's a trigger sensor that recognizes the effort so that it assists the breath. And then in the pressure support breath, the patient makes an effort. That way the machine knows to give a pressure support for the duration of the effort. So 3 of these breaths I just showed you are triggered by patient's effort, and 3 of these are not. The controlled breaths, pressure controlled breaths, and pressure release breaths are triggered by a timer. So I want to go over the 3 T's of individual ventilator breaths. The first we've been talking about is trigger. The ventilator breath can be triggered either by a timer, so that could be that the ventilator breath is initiated by a set rate. Also, a timer could end the breath. We'll talk about that in a minute. Or it could be triggered by patient effort. And I showed you how a change in the circuit pressure or even the flow can be set to say that's when Mr. Smith wants an effort. What I've been showing you so far was a change in the pressure going down was perceived by the ventilator as an effort, but we also can look at the flow change as a trigger for breaths. The second T of individual ventilator breaths is what we call target. We're either going to put in a predetermined flow pattern or a pressure target or a volume target. So I showed you how the pressure in those 3 pressure modes would be, let's say 10 above normal is the target. I also mentioned in a volume mode like assist control, the target might be 500 cc's. Generally, if we pick a pressure target, then we have to check to see what the volume returned to the ventilator. And if we pick a volume target, we have to go back and check to see how much pressure, because in the case of a pressure target, we don't want the volume target to exceed our guidelines of, let's say, 6 cc's per kilogram of predicted body weight in an ARDS patient, or no more than about 8 cc's per kilogram in other patients. Conversely, if we pick a volume target, we need to make sure the pressure is not inordinately high, let's say above 35 peak area pressure or 30 plateau pressure. The third T is the termination rule. So we might terminate the breath when the volume target is reached, or on a timed cycle at the end of the timed target, or in pressure support ventilation, what determines the end of the breath is when we reach a low flow target. That is, the target is, let's say, 25% of maximum flow. We write a rule. The breath is deemed to be over when the flow is low. So I want to go over the anatomy of a controlled cycled ventilator breath. So this is one of the 2 breaths we saw, assisted or controlled, where we control the pressure. I want to just focus in more detail. So we start at a CPAP, which is a pressure above baseline. In this example, let's call it 6. Then the breath fires off of the trigger, and the pressure rises as the volume is delivered. And then when the breath is over, we allow the patient to go back to the PEEP, the baseline pressure. It's called PEEP or CPAP 6. The highest pressure that's achieved is called peak area pressure or PAP. We also have a readout on the ventilator called the mean area pressure. In this example, it's 9. Now, if you think about the pressure, baseline is 6 and the peak pressure is 22. The average of 6 and 22 would be 14. The reason the mean area pressure in this example is 9, not the middle number, is that we spend much more time at 6 than we do at 22. And in fact, we're only at 22 for a little bit of time. We're at 20, 18, 14. So on average, the pressure in this type of a breath is very close to the CPAP. It's only 9 when the CPAP is 6. So a pressure cycled breath has a low pressure, same as on a volume cycle breath. We call it PEEP. In this case, it's 6. And then we have a high pressure called PEEP, high. And in this case, it's 22. Some of the modes actually don't describe the PEEP high. It actually says what the inflation pressure is, the P inspiration. So this patient's high pressure of 22, excuse that this is vertical, but that's a 22, can be described as an inspiratory pressure of 16. It's the same thing. Whether you say the patient's on PEEP low of 6 with an inspiratory pressure of 16 or a PEEP low of 6 and the PEEP high of 22 is identical. So here I'm labeling this as the inspiratory driving pressure or the inspiratory pressure. We also have a certain amount of time we hold the pressure at high, which is the inspiratory time, or T sub I. There is a T sub E in this example. It's a little bit shorter than T sub I, so we'll get to this, but we would call this cadence an inverse ratio ventilation whenever inspiratory time is exceeding expiratory time. It's an inverse ratio. Just remember that healthy people at rest tend to have an I to E ratio that's 1 to 2 or even 1 to 3. So anytime there's an inverse ratio, that's not the normal situation, but we do use inverse ratio ventilation quite a bit. So in the case of inverse ratio ventilation, we find that the mean pressure is higher. If you remember the first patient I showed you, the mean pressure was 9. The average of 6 and 22, which is 14, would be right here. But in this case, we've jacked up the average or mean pressure to 16. The reason that's above 14 or 9 is because we're spending more time at I than E. So we have much more time at 22 than at 6. So the weighted average comes out to be higher than the actual average. So 16 is higher than the average of those two numbers of 14. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.